Welcome back to the podcast Heal Without Harm. My name is Dr. Clayton Dir, physical therapist and the one bringing you the truth about the medical system, specifically about muscles, tendons, bones, meniscus, labrums, and all the things. Today's podcast is over meniscal tears, specifically in the knee, and the fact that a 10-year study just came out saying, hey, not only do we think certain surgeries on the meniscus and the knee are not helpful, but the people who got them 10 years later actually had worse outcomes. I am excited to get into this because I, along with a lot of other physical therapists, and yes, some doctors and orthos, have always been saying, do we really need to do surgery? And if so, how much is it really helping? And are there other ways that we could have prevented this, treated it conservatively, whatever it may be? So I want to get into it. So the study looked at specifically degenerative meniscal tears. This is not like I tore my ACL and my meniscus. This is not, I tore my meniscus and there's a flap of the meniscus getting stuck or getting the knee locked. All of those were a different study. This is the type of meniscal tear that is age-related. Maybe it's fraying. You've kind of slowly developed a knee pain and then they do the MRI and they find like, hey, like your meniscus is degenerating. It's bothersome. It's like, this is the bucket of those people. And so what they did is they essentially put everybody in under surgery. Well, what they thought was surgery. Let me get into the specifics here real quick. It was 146 people. It was in Finland, 146 adults between the ages of 35 and 65. They all had degenerative meniscal tears. They all underwent diagnostic arthroscopy, which means some small holes are cut in the knee. They put in cameras and they look at the knee. During that same procedure, half of them were randomized into a partial meniscectomy, which is a fancy way of saying they removed part of the meniscus, the torn portion, of course. Well, the other half just had the meniscus left alone, which was what we call a sham surgery. And so everybody got cut open. Half of them got a piece of their meniscus removed. The other half were just looked inside and then sewed them up. And what they found is over 5 years, there was no significant differences between the two groups in physical function, quality of life, or knee pain after exercise. However, the follow-up evaluation after 10 years was just published April of this year in the New England Journal of Medicine, and they reached the same conclusion. However, they additionally found that the surgery group fared worse on several measures, including higher rate of new or worsening osteoarthritis, which is the classic arthritis that everybody's worried about. I'll explain that a little bit more in a second. And they had a higher risk of needing additional surgery, such as a total knee replacement. This is where, from my perspective, being one person who sees a lot of people with knee pain, it's like, and this goes the same for back. It's like the second you get one surgery, it's like, guess what? You just started the clock. Like you're going to be on your way to get another one. And I think most people don't want one surgery, let alone 2 or 3. But it's like, hey, surgery didn't work the first time. Let's do 2 or 3 more. Like, it just kills me. I don't understand. But it sucks because I've been with my dad in those orthopedic like consults when they put the X-ray or the MRI up in front of you. And I'm sure they don't do it ill-intentioned, but they paint this horrible nightmare. Like, here's your knee. Look how bad it is. Oh my gosh, I can't believe you're walking on this thing. It looks so bad, so horrible. It's breaking down. It's torn here, like degenerated there. And you're like, oh my God, I need surgery right now. I'm in a lot of pain. This is reinforcing that pain is coming from that degenerated meniscus. I need to get this fixed. And they have a 10-year study that showed like the surgery people were no different than the non-surgery people. And the people who got surgery had worse issues 10 years later. They actually sped up the need for the second surgery, which is way more invasive. Having a total knee replacement is way more costly, way more invasive, way more of a rehab than just simply getting some meniscus cut out. And so I want you to take that into consideration. And they're also finding similar things with the shoulder. Like cleaning out the shoulder, quote unquote, cleaning it out is also no more beneficial, because I would argue that the majority of the time, the structure itself is not the problem. The osteoarthritis is not necessarily the problem. The degenerated, gosh, I need to find another word. The degenerated meniscus is not the problem. It is the result. It is the result oftentimes of your knee not having the full capacity to go into full extension, which is straightening, or full flexion, which is bending, or having the quad capacity, the strength in your quad muscle to support you with stairs, to support you with walking, with running, with jogging, with squatting, with lunging, with all of these movements. That's the problem. And guess what happens? Guess what happens when you don't have the strength in the knee or the hip or the quad or the hamstring? You start creating degeneration. You start creating osteoarthritis. And then surgeons on their white horse, I'm getting a little frustrated here. Surgeons on their white horse come in and say, look, you have this breakdown. I can replace that for you. It's like, well, why is that breakdown there in the first place? Part of it's you're just getting older, and that's okay. That's acceptable. Not you need a knee replacement. It's just like, yeah, those are age-related changes. Those are things we expect to see in a 40, 50, 60, 70-year-old knee. But why is it there in the first place? Why is it worse than all these other people? And I've been talking to people in Ghana, in Kuwait, in Dubai, and they all have a very similar story. It's like, your knee is bad enough to where you can't live the life that you want, but it's not so bad you need me to replace it, is what they're getting from their doctors. So they're left in this horrible limbo where if you can get to a good physical therapist who is going to evaluate your knee and say, here's the weakness, here's the range of motion deficit, here's what we're going to do about it, it's pretty straightforward most of the time. And people are getting pain relief within days, weeks, and they're not getting cut open. They're not risking a faster total knee replacement. They're not risking everything that comes with surgery. They're not risking potential like increased chance of osteoarthritis. That's the difference here. And that's why I'm so strongly focused on doing conservative care, like physical therapy, good physical therapy. That's what I want. And then I do want to take a second to explain osteoarthritis. So when people say I have arthritis, I think a lot of people, the way they word that is they word it in a way that they feel like they've caught a disease. Like, oh no, it finally got me. And it's like osteoarthritis is just like the result of weakness, like an overuse of that joint secondary to the weakness it has. And it is very, very different than rheumatoid arthritis. Rheumatoid arthritis is like a systemic autoimmune type disorder where the body's actually attacking its own joints. Osteoarthritis is just visible changes secondary to instability within a joint. And yes, the arthritis can be painful and flare up, but it wouldn't necessarily be there as bad as you may have it if your knee, hip, joint, whatever it is, was strong and stable. And you have that arthritis, and guess what the first line of defense is? It's movement. It's exercise. Where you're at, right? If you have knee arthritis, I'm not going to say, let's do 100 squats. I'm going to meet you where you are, and I'll give you an open chain movement, like sitting on the edge of the table and just bending and straightening the knee with zero load, with no resistance, right? Very easy. Then you get on a recumbent bike, then you start doing some squats, but only down to a chair, and then we progress up from there. If this sounds like what you're wanting, you are wanting that path forward that doesn't require surgery, then I suggest, one, you get a consult or an evaluation with a physical therapist. That could be with me. That could be with a physical therapist in your area. You can reach out to me. All my info's at the bottom of this podcast. If you want some sort of a guide, a protocol, because you don't live near me, you don't live near a physical therapist, or you're just more of a DIY type person, you can absolutely reach out to me. I've got my school community in the description below. I've got a full knee pain protocol there that you can go through yourself, self-paced. I tell you what to do, when to progress, give you the videos. It's all patterns and exercises based off how I've treated this before. But a lot of the times people want that one-on-one care, and I totally get it, and I'm here for you. I can help you find a PT near you. I can chat with you on a video call, or you can just come to Wichita, Kansas, and I'll help you. But I want you to know that knee pain, specifically from degenerative meniscal tears, is not a surgical candidacy, and you need to see a physical therapist to best help you. If you guys have questions, reach out to me. If you want a protocol, it's down below. If you want a community of people that have done what you're doing, are currently doing what you want to do, and you just want that mentorship out in front, my community on school is called the Doctor's Home PT Method. Would love to have you there. We have tripled in size over the last week, and I would love for you to be one of the ones to come in, get results, help others get results, and prove that you do not need surgery. And overall, I hope you help me teach others how to heal without harm.